Good evening, everyone. And I'm your host, Dr. Pratibha Singh, Chairperson of International Academic Exchange Committee, Fogsi. And it's my absolute pleasure to welcome you all to this 196th episode of Gyan Pravah, a name that beautifully reflects our mission, the continuous flow of knowledge. Now, this isn't just a number. It's a celebration of shared wisdom, thought-provoking conversations, and Foxy's unwavering dedication to academic excellence across borders and specialties. So you see, every episode is a step forward, empowering minds and enriching women's healthcare. And today, I feel especially privileged to welcome our President of Foxy, Dr. Sunita Tandulwadkar, ma'am. Although she has to leave shortly for Delhi, so she has made the time to be here with us. So thank you so much, madam, for joining and sparing your time. And as we all know, that the imagination is the foundation of both invention and innovation. And today, we are honored joined by a visionary who truly imbibes this spirit, a world-renowned hysteroscopist who has revolutionized operative hysteroscopy with his groundbreaking innovations and a true game changer in this field. And we are really privileged to welcome our distinguished guest, a brilliant innovator, Dr. Giuseppe BIGATTI. So welcome, sir, to this podcast today. But before we begin, it's my honor to introduce our President Foxy, Dr. Sunita Tandulwadkar, madam. She is at present the President of Foxy 2025 and President-elect of ISAR for 25-26. A globally acclaimed IVF specialist and minimally invasive surgeon, and she has received many awards and accolades. And among his many remarkable achievements is a historic milestone, delivering India's first stem cell baby in 2018, which was also the world's first stem cell baby born to a 45-year-old woman. So with this, I request madam and invite you to bless this podcast. Over to you, ma'am.
Thank you, Pratibha. Thank you so much. And welcome, Professor, on this beautiful Foxy podcast series, Star Pravaha. We, in Foxy, we function like a president is always at the helm, assisted by 5 vice presidents and 30 committee chairperson. Pratibha is with the International Exchange Committee. And these 30 committee chairpersons, they function in various small parts of OBGYN. Now my 30 committee chairperson takes 30 days, 30 work podcast. And I felt that it is just to give them the platform so that they become more creative, confident, their oratory skill, their exposure, people will recognize them. So many ways to promote my chairperson was this small attempt. But when we are reaching now to near 200, I realize meeting every day 8 p.m., one of the faculty of a national or international stature, from academic till non-academic. We do have a political background, we do have a philosophical, we do have a spiritual background, so many faculty who have joined this podcast. And I think meeting those 200 faculty was a huge learning experience for me as well. It evolved me as a person. So today, we welcome you on a Foxy platform. And Pratibha, thank you so much for always coming out with the brilliant faculty. And your podcasts are always one of the best podcasts you always have. So I wish you all the best for this dialogue. Our protocol, doctor, is you both will be in the podcast, in the views, and I will join the viewers link to listen to both of you. So enjoy your dialogue with Pratibha, but I'll be here till she introduces you. Sergio and all are my very close friends. He comes to India to me and I come to Global Hysteroscopy many times.
So thank you so much, madam. Thank you so much. And now it's my privilege to introduce a remarkable personality who is not only a distinguished gynecologist, but also an innovator in his field, Dr. Giuseppe BIGATTI. So welcome, sir. And He holds an impressive CV filled with numerous accomplishments. He earned his medical degree from University of Pavia in 1980 and 89 and went on to specialize obs and gynae at the University of Milan in 1993. With deep focus on hysteroscopy and laparoscopy, he dedicated his career to advancing research and training in these fields. As a world-class expert in hysteroscopy, he is best known for inventing the intrauterine BIGATTI shaver, a revolutionary device based on his extensive experiences in operative hysteroscopy. The IBS or intrauterine BIGATTI shaver has been widely recognized as one of the safest and most precise tools in operative hysteroscopy, and compared to traditional techniques, it significantly reduces trauma and bleeding and gently shortens the procedure time. It is developed in collaboration with Karl Storz. The IBS offers major advantages in the treatment of intrauterine pathologies, including improved visualization, faster procedures, and lower complication rates, particularly in hysteroscopic myomectomy and the removal of placental remnants. So great achievements, sir. And along with this, as a special recognition of his expertise, Dr. BIGATTI has served for many years as a tutor in hysteroscopy and laparoscopy, training medical professionals across Europe and Asia. And he has also led workshops in countries including Austria, Belgium, Slovakia, Greece, Italy, etc. And he has also published extensively in international medical journals and has been an invited faculty member at conferences across the globe. Notably, he became the first foreign doctor to hold a full-time director post at state-owned hospital in China, that is in Shanghai, a center focused on the diagnosis and the treatment of intrauterine diseases. And he is also the recipient of many awards, which includes prestigious Raoul Palmer Award, ESGE Award for Best Video Presentation at European Society for Gynecological Endoscopic Congress. And his work is shared on platforms like Academia, Edu, ResearchGate, and he's also actively engages with medical community through social media, including Instagram and LinkedIn. And currently he serves as the medical director at La Clinica, a private hospital in Milan, Italy. And beyond, share a few words with us on this podcast before we formally start our conversation. Over to you, sir.
Well, first of all, thanks very much, Sunita and Pratibha, for this fantastic introduction. And this is true. What you said is my life has been dedicated to hysteroscopy. I was a normal gynecologist. I was in a normal hospital in Milan. And then once I introduced the intrauterine BIGATTI shaver, my main topic became hysteroscopy. So since then, my work has been in this trend. What was really good is to go to China, because in China, actually, I was the first foreign doctor to have a leading position in a public Chinese hospital, and this is very, very difficult for China. And we built up a unit only dedicated of hysteroscopy, and we performed almost 13,000 cases of BIGATTI shaver. So this gave me the opportunity to speak better about this technique. So thank you very much for this invitation, and thanks to all the Indian physicians who will listen to us today.
Thank you, sir.
Thank you, Pratibha, and thank you, sir. Wonderful to see you, meet you, and looking forward to see you sometimes in person. Thank you.
I will try to come to India as soon as possible.
We'll have you, sir.
Thank you so much, madam, and all the best for your journey. Thank you. So, sir, now we'll start our conversation. So welcome once again to this podcast, which is basically on your BIGATTI shaver, IBS shaver. So first question, which I would just want to know, that what developed you, what inspired you to prepare this, to develop this BIGATTI shaver?
But you see, the idea, the real idea, belongs to 1992. I was born in 1962, so I was 30 years old, and I was sent by the leader of my hospital, Professor Polvani, of the University Clinic in Milan. I was sent to Belgium, to Leuven, where I spent 1 year, and where I had the opportunity to meet people like Bruno Van Arendal, Rudy Campo, all these people who then became very popular in the hysteroscopic field. And at that time, I went to a meeting in Bonn in 1992, and it was a microsurgical meeting, but there was also a live surgery demonstration. So there was a British physician who made a beautiful speech about complication of hysteroscopy. Then he performed a live surgery, and he had a lateral perforation. Because of the view was very bad. He had a Japanese flag in front of him, and we know by hysteroscopy, when you have the Japanese flag in front of you, when you don't see, you should stop your procedure. Unfortunately, he carried on, and he made a lateral perforation to the cervical canal. So it was really a very bad perforation. They had to open the patient, and the patient really risked much, only for an hysteroscopy, for a polypectomy, I guess. So since then, I remember I was watching this operation, and I say to myself, why can't we make hysteroscopy easier? I mean, why can't we should improve visibility in hysteroscopy, and the only way to improve visibility in hysteroscopy is to remove the pathology at the same time as you dissect it. So the idea came from a live perforation, and the idea was to make hysteroscopy different, easier. So the idea belongs to when I was 30 years old. So it took many years then to develop the technique, to convince the company to create a new device. But actually, the idea belongs to this period of my life when I was still a resident. I was 30 years old.
So, sir, what is the difference? How it is differ from the traditional electrosurgical or resectoscope? How does it differ from that?
The key
How
point,
do you think that it is so safe? Yeah.
No, the key point is exactly what I told you. In order to have less complication, you should be able to remove the pathology as far as you dissect the pathology. The resectoscope uses electricity, it needs a lot of training, and is very dangerous because the space we are dealing is only a 4 cc space. I mean, the uterine cavity is a very tiny cavity.
Yeah.
Even if you distend the cavity with fluid, but once you start to dissect even a large polyp, not necessarily a myoma, if you have a large polyp filling the whole cavity, it becomes very difficult, because after you make some few slices, your visibility is impaired.
Yes.
So the only way to improve the visibility and to see always what you are doing is to cut the piece of tissue and bring it out. That's the key point. Actually, was the idea which belongs to when I was 30 years old, and all my life was dedicated to find a solution to this problem.
Yeah. So while you were designing this instrument, so do you find face any challenges while designing this and while coming out with this IBS shaver? Any challenges you faced?
No, there has been many problems, because the instrument that you are using today is the result of a 10 years experience. So we started with a very simple device, which was you had actually the shaver is made of two parts. One is an optical part, which is your eyes, and the other one is the shaver, which you introduce into the optical system. So at the beginning, once I did the first case, it was in 2009, actually the first case. I introduced the optic, I could see the myoma, then I insert the shaver, and suddenly all the water came out, because the aspiration was a continuous aspiration. So the cavity collapsed. So I had to ask the nurse to close the aspiration. We were using the aspiration of the operating room. So he closed the tube just by hand, by doing this, and then I gained visibility again. So this, just to tell you how many challenges we had to find. Then we had to find the right size of the blade. We started with a very tiny blade, and then we enlarged the window. The inner blade was a single window blade, like a spoon, and we changed the inner blade to a double window blade. So really, it took many years to have
finally reach to the proper way.
It took really many years. So now you go inside the uterine cavity, you see the polyps, you see the myoma, you insert the shaver, and you start shaving, and you have never the collapse of the uterine cavity. So you also have to establish some parameters like the speed of the blade and like the power of the aspiration you get. If you get a strong aspiration, the cavity will collapse. And so just to tell you that there have been many problems to solve. And still, I still think that the device we are using is still a very primitive device. We can do much better in the future.
So, sir, what all pathologies, like you said, polyp we can remove it. It is while a shaving way we remove it, or myomectomy. What all rest other pathologies you can do? Like if there is a septum, if there is any other, are those also can be done with this your IBS?
You see, now we call it intrauterine BIGATTI shaver. Originally, IBS, the I stayed for integrated BIGATTI shaver, because the original idea was to give to the surgeon a device in which you could approach all kinds of pathologies. So if you want to change, to go from receptoscope to another technique, you should be able, with the new technique, to do almost everything. So right now, I think the only the real limit of the shaver are large myomas. Myomas bigger than 3.5 centimeter are still a challenge to the shaver. That's why there is a space of improvement. Regarding the rest, you can do everything because you have an operative channel in which you can insert big scissor, big forceps, which are not the for French, the 1 millimeter instrument, but they are the 4 millimeter instrument, especially with the 19 French shaver. So these instruments are very big, they are very strong, so you can cut septum, you can cut synechia, you can do the T-shaped uterus correction, you can cut the myoma in pieces and then use the blade. So actually, really, you can do almost 99% of all cases with the shaver without using any other device. And this has been proven in China. So I tell you this not because I am the inventor of the shaver, but I went to China, and in our center, the number of resection in 5 years has been 25 cases. So that's the 25 cases on 13,000.
Okay.
Shaver procedure.
Very impressive. Very impressive. So, sir, what I was reading in your CV also, that it reduces the risk of complications and fluid overload or uterine perforation. So, how much it? I mean, can you tell me about the complications apart from this, or if this is also a complication for shaver also?
I think the shaver has a less number of complications because the training, the learning curve is much faster, and because of the visibility is much better. So the number of complications are less, but there are complications. And they are, if you have a complication, they are certainly less severe because you are not using electricity. It's a mechanical complication. So you can, in China, we had mainly few perforation and only one severe perforation in which we had a bowel injury. That's the only case, one case on 13,000 procedure. So the perforation is still possible because it's not depending on the technique, but is depending on the surgeon. This is the problem. And regarding other complications, you can have some excessive bleeding, especially when you deal with placenta remnants. If you don't follow specific
Protocol.
yes, if you don't follow specific rules, you can have a heavy bleeding, especially on placenta remnants, and this is another possible complication. Fluid overload, it's only depending, actually, for 80% of the cases, you're very fast. I'm talking about polyps and soft tissue, which are about 81% of all the operative procedure. You are less than a minute. The time of resection is less than a minute. So, of course, there is no complication regarding fluid overload. You can have a fluid overload complication if you deal with large myomas. Of course, that's why I told you for myomas, you should put a limit to 3.5 centimeter. Don't go over, or be sure that if you go over, that the myoma is tender. I don't think that you can do the same as you do with polyp. With polyp, it's seconds. With the myoma, it takes still today from 5 to 25 minutes. In this case, you have to take a very, you have to pay a lot of attention regarding the fluid overload. And stop when you see that your fluid becomes over 2,000 2 liters.
Yeah.
And in this case, you can plan a second step procedure, or if you see that really the myoma is huge, then you should go with the receptoscope still today. But as I say, the complications are less and less severe. It's important that you recognize the complication. What you really reduce in terms of complication is that you have a much lower risk of gas embolism. And this is because once you are inside the uterine cavity, you activate the shaver and you finish the procedure without going in and out.
Okay.
So by doing this, especially if you do myomas, with the receptoscope, you dissect a lot of pieces, then you have to stop, remove the pieces, and go inside the uterine cavity again. So you have a sort of pump movement. You bring water into the cavity. So this is the gas emboli is really much lower than receptoscope. And this is very important because the biggest complication of operative hysteroscopy is gas embolism.
Yes.
I mean, perforation, you realize you have perforated, you stop, and you check the patient. But if you have a gas embolism, sometimes you might lose the patient. So reducing gas embolism has been already a big advantage of this technique.
Now,
Okay.
like we are also doing hysteroscopy, but we have never used this shaver. So what should be the learning curve for those who want to learn this IBS, use IBS?
When we started our technique in Milan, one of the theses of one of my, actually, it was a colleague, not a resident, because I'm not from the university, but she took the degree of the medical school and she made a study, she made a comparison between receptoscope and shaver. It was a randomized control study. And she proved that with the shaver, even if between a resident and an expert surgeon, even if the resident had bigger polyps, we compare only on polypectomy, the learning curve was the same between an expert surgeon and a resident. The resident even was faster than the expert surgeon. For the receptoscope, it was not like this.
Okay.
The learning curve was much longer. So we already proved that the shaver after 2-3 operations is much easier than the receptoscope. The difficult part of the shaver at that time was the setup of the whole instrument, which needs a little bit of knowledge. But after 2-3 operations, also the nurse can be independent to do the setup. So the use of the shaver it is really easy. And also the skill comes almost natural after 3-4 cases. And this is remarkable.
So sir, can we see that, can we see that IBS shaver instrument, if you can show us on this podcast, can we have a video on that?
Yes, I prepare a video in, I can try to, I don't know how to, I think I know. I have to
Share the screen with that. You can do it.
share. Screen,
Down there is share the screen.
but I cannot open. Here it is. Can you see the video?
Yes, sir. I can. Since started it.
Can you see completely the video?
Yes, sir. Yes, sir.
So this is a video which was made in Moscow. It was a live procedure. So there was a polyp. You see, the visibility is very good. And there is a small polyp inside the cavity. So
Yeah.
you just do a rotation of 90 degrees and you remove the polyp in terms of seconds. So this is a nice video because first of all, it's a live procedure. So it's been not, has been edited because I tried to cut some small parts which were not useful to see, but it is almost all a live procedure. So you see the cavity is in front of you. You can clean your view very well with the shaver. And you see there is a lateral myoma to the left isthmic wall. It's a G2 myoma of 3 centimeters. And I just proved that the first thing you have to find is to try to find the cleavage plane between the myoma and the wall. And then after starting like this, you have to reduce the speed because the normal speed is 2,100 rotations per minute. You have to bring the speed to 1,500 rotations per minute. You see the blade is going much slower, and you should increase also the aspiration, just keeping the window in contact to the tissue you want to remove. When you increase the aspiration, if you go to 250 to 500 or even to 1,000, the aspiration is very strong. So if the blade is not in contact with the tissue you want to remove, you will aspirate water, you will reduce the intrauterine pressure, and the bleeding will increase. So this is I mean, for myoma, you need some skill. So my suggestion is to start with soft tissue, with polyps, with endometrial hyperplastic tissue, and then move to small myoma of 1 centimeter, 1.5, 2, and then go up to 3.5 centimeter. I put a 3 centimeter myoma in this case, but probably is much bigger than what we think. You will see at the end. You see, another trick is to go under the myoma. So once you find the cleavage plane, you see the pink tissue on the back is the normal tissue, is the base of the fovea. So we are trying to remove the myoma from the fovea. So you go under the myoma, not on the top, and you should see the tissue dancing. You see that the tissue is moving. This movement of the tissue, my friend Rudy Campos said, you should see the tissue dancing. You see it's moving.
Yes.
And when the tissue is moving like this, it means that it's been removed by the shape.
Okay.
The whole operation in this case lasted 15 minutes. So the editing of the video is very, very little. This is the place where the myoma was. You can see the big fovea left by the myoma, and you see the cavity. Normally, the normal cavity has is large 4 centimeters. So if you see the comparison between the fovea left of the myoma and the cavity, probably this myoma was bigger than 3 centimeters. But as I said to you, try to limit yourself by ultrasound to myoma which are not bigger than 3.5 centimeters. If you do like this, you must be you might be sure that you finish the procedure in one step. Another thing you can do, if you see that the myoma is too big or too hard to be removed, you try to enucleate completely the myoma from the fovea, and you push the myoma inside the cavity. So if the piece which is left is too big and to be removed you see the size of the cavity compared to the size of the fovea, and then you can use the bipolar probe to coagulate.
Okay.
It's very precise, and also the visibility when you do like this becomes even much better than before. But this video is nice because give you the possibility to see the polyp, to see how to remove a myoma. You see the large, the cavity, the white of the cavity is it's probably okay. How do you go?
So I think, sir, in India also, once I have seen this case being performed by Dr. P.C. Mahapatra. He has once used one shaver, but that time I was not knowing that it was long time back. I think 3, 4, 5 years back when he has used that, and he has resected this because it moves with the ultrasonic waves. What exactly that blades move?
You mean the speed
Sir,
should
can you
be
unshare your screen?
how do I do? Stop to share.
Yeah. Yes.
You see me now?
Yes, sir. Yeah.
I see myself in the corner. But I hope that you see me. So you were asking the real speed of the blade, no?
Yes.
So the speed of the blade should be 1,500.
Okay.
Normally, for most of the cases, you use a speed of 2,000, 2,100. When you deal with myoma, your blade has to go slowly. So you have to go from 2,000 to 1,500. Don't go less because the blade will not work. The movement inside the blade is an oscillatory movement. It's not a rotatory movement. So the inner blade oscillates within the outer blade. So it's important you reduce the speed and you increase the aspiration.
Okay.
This is.
So, sir, and where all, I mean, this shaver has been popularized, like all the hospitals. I mean, in India, I think still it has not been, people are not using. I have not seen that way. So, can you throw light?
I think it has been also sold in India, but
yeah, that is what I have seen Dr. P.C. Mahapatra operating with this. Yeah,
but I don't know anything about commercial. I think this
Okay.
has to be asked by stores people. The only difficult for developing country, which is not more the case of India, because now India is no more a developing country. We are a developing country, and your country is a leading country. It's different. Is the cost. Because they are afraid about the cost, and this is not a real issue, because you see the cost of one set of the shaver is not little at the beginning, but because it is a reusable device, you can use this device forever. In China, we had 7 shaver, and they are still all working with minor adjustment. So if you think we did about 13,000 procedure in 5 years, you cannot expect that for each procedure you pay for a disposable device. So our 5 shaver were always running. The only cost was water for the instrument and the doctors, and that's it.
So those blades, they don't break.
No, they are difficult to break. They are very difficult to break. You need to do some maintenance on the handle, but the blade, unless you really bend the blade, they work forever. You see.
Okay. So anything more new invention which you are planning apart from this?
You see, any new technique is a living creature. No, it's never. So we are at the beginning of a new, I always say, is a new era of operative hysteroscopy. This device is very good, but needs to be implemented, needs to be, there is always space for improvement. And this is the best part of this technique. For instance, we should be a little bit faster on myomas, because if we proved in China that we can do almost all cases, but the time for myomectomy is still longer compared to the polyps. So if you want to cut down on complication like fluid overload, you have to be faster. So there is a space of improvement in this. Another thing which can be improved is the coagulation power. Now, if you want to do some coagulation, you have to take out the shaver and put a bipolar probe inside the operative channel of the shaver. So you lose time. So there should be the possibility to do the coagulation with the tip of the shaver. So you just coagulate and then go on. So you need to stop. No need to go in and out.
In and out again.
This is just some of the improvement you can do.
So, any advice to our young gynecologists?
Use a new device, but try to put something in this device.
Because using a resectoscope, it is difficult. Like many of us can do the normal small procedures, but for using a resectoscope, you need really require a good expertise for that.
Yeah, first of all, the resectoscope is very delicate as device.
Yeah.
Then, especially, there has been a trend to reduce the size of the resectoscope, the Gubini system, or even the Storz system of 15 French, but it's very delicate, especially the loop, so it breaks in.
Yes.
So there is a cost. Every time you break a loop is a cost. And then there is the question of the learning curve. If you take a resident and you put in the hands of the resident the shaver, after 2-3 cases, you can leave the resident with the shaver to do most of the procedure. If you do this with the resectoscope, you might have a very bad complication because it's difficult. It takes I was raised to use the resectoscope. You see, in my career, I only had the 26 French resectoscopes. So I had to do a dilatation until 9.5 and then put the resectoscope. It was difficult. I was using sorbitol mannitol because there was monopolar. So I know the problems you have with to use the resectoscope. The way of moving is difficult. It's not so easy. The space is tiny. So resection really needs a lot of skill. And I personally think that the shaver will be the future because it's much easier for the physician, for the surgeon, because you always see the trick is that you have always the surgical field in front of you, and this is the best part. And you should always have the surgical field in front of you. Don't make slices and impair your visibility. The only way to have less complication is to be fast and to see better. This is the trick. So, and these are the two qualities of this device. You see better and you're faster.
Fast.
This is my idea for Pratibha.
So thank you, sir. And anything else you want to tell about IBS?
No, I think you made good questions. I think I explained almost all this new technique. What I can say really that in China, the reason of my to take a decision at 56 years old to leave Italy to go to China is because the Chinese government gave me the opportunity to build a unit completely dedicated to hysteroscopy. So you can imagine, I had 3 doctors working for me, and 2 surgical room, completely new, a sterilization in the middle. We wrote some beautiful guidelines about this center. There is a book with the guidelines, which I put in the group, in the WhatsApp group, so you can download it for free. And this organization was really excellent. And you see, why China? Because I think China and India are the same because you have a high number of population. So the only place in which you can justify a unit only for hysteroscopy could be China and India. You see, because this center used to be on 1 OR, we did the diagnostic hysteroscopy and small office procedure like small polyps. And then if we found something big, we planned the operation in the other room. So we prepared the patient, and we were doing every day from 20-25 operation in 1 OR and 10 to 17, 18, 20 diagnostic in the other OR. So we had a media of about 100 procedure per week, talking about media. So, and all the procedure were done with the shaver. Only a few cases I was doing the resection. And as I told you, we had two severe complications in actually 6 years' time, because I stayed in China 6 years. But we in the center we worked for about 5 years. So the number is impressive. In total, they will finish this year with 20,000 procedure in total, with about 13,000 IBS procedure, and the rest were diagnostic. So,
because when we see now in the laparoscopy, when we remove myomectomy with the shaver, it becomes very difficult. I mean, everybody is very much afraid of that. Yeah. So
the laparoscopic morcellator, no?
yeah.
And you see also the laparoscopic morcellator
Yeah.
is it should be improved. I mean, the
Because
technique.
we have seen many accidents with that. So,
but you see, the shaver is not a morcellator. It works in a different way.
yeah.
There is only one device made by another company who has a movement which is exactly the same as the laparoscopic morcellator. But you see, because the laparoscopic morcellator works because it is sharp.
Okay,
So you should be able to remove pieces of myoma by sharpness.
Yeah.
After a while, even the laparoscopic morcellator lose the cutting power. Imagine if you have an hysteroscopic morcellator, which is tiny.
Yeah.
You can use it only once because the cutting power is lost one procedure.
Yeah.
And also in this case, you need to have tender myomas or small myomas. If the myoma is too big, even these. I really prefer to speak about the shaver technique, because the BIGATTI shaver it has no translatory movement.
Yes,
We took advantage of the oscillatory movement. It's like shaving the beard in the morning, no?
Definitely.
So is the shaver technique is different. I don't mix the two, but the laparoscopic morcellator should be improved.
Yes.
You see, in laparoscopy, what is I found not correct is that you first have to enucleate the myoma, and it takes a lot of time, and you have a lot of bleeding, so for the patient is not good. Then you have to remove the pieces.
Yeah.
So you have two steps, which
yeah.
make the procedure too long. That's why most of the surgeons, they prefer to do a mini laparotomy. They bring the uterus to the wall, they remove the myoma, it's finished in 20, 30 minutes. You see, there is that's why the shaver in hysteroscopy is good.
So that is the difference between shaver and the morcellator. That is important to understand. It is.
There is a beautiful video which is on YouTube and also in my group. There is a polyp which is filling completely the uterine cavity, so you don't see the cavity. You start from the edge, from the top of the polyp, you remove it, and you clear all the cavity in 1 minute and a half. So it makes your life easy, much easier compared to the past. If you think to do it with a receptoscope, it's difficult, very
difficult. Yeah, definitely, because sometimes you need 2 sittings for that. In one sitting, you are not able to take out. In 2 sittings, you have to do it.
You said something before. You asked me something before about the new development. When I made the shaver for large polyp, for large myoma. Then, and I'm working with the 24 French optics, which is 8.8 millimeter. Then there has been a development in the 19 French. The optical system goes from 8 millimeters to 6.3 millimeter, which is good for the big things. It's the same as the 24, but the dilatation is less. So the 24 probably will go out of the market in short time. And then you have the 15 French now. 15 French is only 6 millimeter. So people who likes to do office procedure, I'm not very fond on office procedure. I have to tell you the truth. I still prefer to give some anesthesia to my patients. I work, even if it's for a polyp of 5 centimeter, it takes 26 seconds. I don't care. I mean, with the 19 French, you have to do a dilatation until 7. With the 15, probably you don't even have to do dilatation. But anyway, to have the patients awake, for me, is not the best option. I still prefer to have some conscious sedation, like in Belgium. In Belgium, they cannot do office procedure. They always give small anesthesia. So if the patient has Conscious sedation, I work easily, I work more more comfortably, and the patient doesn't suffer. So why not?
Yeah, definitely.
But
Correct.
with the 15, probably, if you cannot give anesthesia, you can approach some cases. 15 is only 5 millimeter,
5.
which was the original optics I used to do diagnostic hysteroscopy when I started my career. So now you can do operation. The shaver is smaller compared to the 19, but it works. It works well. You cannot do myomas probably, but I'm not sure because the 15 French has just came to the market, so it needs to be tested.
More definitely. So thank you, sir, and it was wonderful talking to you about ideas. Now, a few personal questions I would like to ask you.
Thanks.
So I know you are very busy, always doing such innovative work. So, but still, I just want to know, how do you spend your free time?
No, well, no, I have to be serious in this field. No, I cannot make jokes to you.
No, sir. Seriousness should be till OT. After that, you should be free man.
No, I like to do some sports. Especially when I was in China, I used to go running two times a week. Now I stopped, unfortunately. I like to go running very much. In winter, I used to like to go skiing, but now I reduced also this, and I like to play a little bit the piano.
I read that you are also a piano player.
Yeah, but I'm not good.
Something related to music, so you are. I'm
not a good piano player. I play only for myself. I go running. That's the only thing I still go. I'm 62, but I can still run 10 kilometers.
Definitely.
I can still do that.
You look young. You look young. And then I also want to know, who was your mentor? Is there any mentor for you who has made you, who has realized you, made you realize that this type of things should happen?
No, I have to tell you that probably the guy the person who mostly influenced my career was Dr. Campo from Belgium, Rudy Campo from Belgium, because we started together with courses of hysteroscopy when we were both very young, and he really gave to me the passion of operative, of hysteroscopy. There are many people who influenced me, but probably my friend Rudy was the one who had the most influence on me. And I think the second was my father.
Okay.
Even if he was not a gynecologist, but he always tell me that if you want to do a business, you have to any work you do, you have to look to the star if you have to reach a small mountain. So try to look to the star always. And so these are the two people.
And when did you think, what was that moment when you truly felt that yes, BIGATTI shaver has made a real difference?
Yeah, there has been one moment. There has been one moment. I normally am invited to go to Moscow to a meeting organized by a friend, Leila Damian. She always arrange a meeting in January and in June. And one year, it was before I went to China, so I'm talking about 2019, I think. There was a live session, live hysteroscopic session, and Professor Jacques Amour was working in one OR, and I was working on the other OR.
Okay.
So to be put at the same level of Jacques Amour, who is the most famous hysteroscopy in the world, gave me the idea that probably the shaver was doing well, and I was
must be a proud moment for you. Yeah, it was really. So now another question: if you wouldn't have been a doctor or an inventor, then what you would have been? Apart from, I know those who are doctors, they feel that they can only be a doctor, but
no. Since the 5th year of high school, I wanted to become an engineer. I
Okay,
really want to
that is
become.
why you have come in innovations.
Probably also
Yeah.
this very curious. So that's why. But I wanted to be an engineer. Then I had a problem to my knee because I told you I was always been running in my life, but unfortunately I'm too heavy to run, so I couldn't reach good level. Even if I love this, I love the marathon. But so I had a problem to one knee. So I went to this fantastic orthopedic. It was very nice, very funny. And I say to myself, because at that time, if you were an engineer, you did not work with computer. You were working on it around the big table.
Yeah.
I don't know what it's called in English. And you spend most of the time making design or making calculations. So I say, well, I prefer to deal with with people. And then by joke, what would you like to be between the doctor? Because I like women very much. I said, okay, then I become a gynecologist.
Definitely.
That's that's the truth.
So wonderful. So, any other guiding force for you, or
Any other?
guiding anything apart from God? You feel that whom you should rely, anything, or
No, I
any
think
or any message you want to give to the youngsters?
I told the only message I think is important to the young doctors, to the young gynecologists, is always to put something of themselves in what they are doing. Don't limit to follow, to do the routine work. Routine work makes your profession not interesting. After a while, if you always do the same, you lose the passion you had at the beginning when you were young.
Like
And
from India,
also,
if somebody wants to learn IBS shaver, how to use it, how people can
we
come?
no, because I just came back from China this March. So
Yeah.
it's a few months that I'm back to Italy, but I'm still traveling a lot because of the training of the shaver. And we are planning to make a course in May 2016, only based on the BIGATTI shaver technique, because I personally think that there is a lack of training, even if it's easy. But if you know two or three tricks by hands-on, it's much faster. I mean, there are some things you have to know also by using the shaver. If you are completely alone and you start with there are many possibility online on YouTube, but it is never like being on a hands-on workshop. So we would like to organize a hands-on workshop. Now that I know that only in the GESEA program there is one station dedicated to the shaver, but there are no training courses. So we are really planning to make a course in 2016 May, which will be for no more than 40 people, in which international. So we will try to have people coming from all over the world. It's me and a Greek colleague who wants to organize this, and we are planning to do this 2-3 times per year, so that we train a lot of people.
Definitely. So that will be a good thing for all the youngsters to follow this and to learn your IBS shape. So thank you, sir. And now I think we should conclude our session. So anything else you want to share with us, sir, before we
No,
conclude?
thank you again for this invitation. You have
Thank you so
been
much.
behind me since 1 year, I think, because we planned this meeting 1 year ago.
Yeah, definitely. Yes, sir.
And,
So as we conclude this enriching episode of our podcast, I feel truly privileged to have had the opportunity to speak with our esteemed guest, Dr. GCP BIGATTI. So thank you, sir, for generously sharing your knowledge, expertise, and innovative ideas on hysteroscopic procedures. Thank you
I
so
hope
much.
to meet you in person.
Your
in future.
insight into the BIGATTI shaver has shed light on how this groundbreaking technology can make hysteroscopy safer, faster, with improved visualization. And I'm confident that valuable information which you have shared with us today will help many practitioners refine and enhance their hysteroscopic technique. And while science and medicine continue to advance at a rapid pace, it is crucial that we as a practitioner remain open to innovations and evolutions in our daily clinical practice. And this BIGATTI shaver stands out as a remarkable innovation, one that has the potential to become a true game changer in hysteroscopic surgery. And I sincerely hope more clinicians will explore and adopt this technology to improve patients' outcome. So once again, heartfelt thanks to you, Dr. BIGATTI, for
Thanks.
taking your time with us today, and your contributions are deeply appreciated. Thank you so much. And
Thank
with
you.
this, I also want to extend my gratitude to Dr. Sunita Tandulwadkar, Madam, President of Fogsi, for providing us with such wonderful platform that encourages continuous learning and meaningful academic exchange. And it is through such innovatives that we as a medical community continue to raise the bar and stay at forefront for the progress. And to all our viewers, thank you for joining us. And I'm sure it must have been a great learning experience for you all. So until we meet again, let's keep learning, growing, and striving towards a healthier tomorrow. Stay hopeful, stay informed, and take care. Goodbye, good night, and thank you. Thank you.
Bye-bye, Pratibha. Thank you very much.